This 3D map of the posterior abdominal wall shows the precise retroperitoneal positioning of the suprarenal or adrenal glands. They sit at the supromedial aspect of each kidney, spanning the T11 to L1 vertebra levels. Each gland is highly metabolically active, yet remarkably small for its physiological output. It weighs approximately 4 grams and occupies a volume of just 5 centimeters in length, 3 in height, and 1 in thickness. The surrounding abdominal architecture forces a distinct macroscopic shape on each side. The right gland is pyramidal, perched directly superior to the upper pole of the right kidney. The left gland is crescentic, curving along the medial border of the left kidney. While both the kidney and the suprarenal gland are enclosed within the same outer layer of renal fascia, they do not share the same immediate compartment. A thick, fibrous septum permanently divides the two organs. By maintaining an independent fascial pocket, the highly sensitive endocrine tissue is protected. If a kidney becomes mobile or drops in the abdomen, the suprarenal gland remains securely anchored in its original position. Externally, the suprarenal gland appears as a single, uniform unit. Internally, it operates as 2 completely distinct organs housed under one capsule. This cross-sectional diagram reveals the sharp anatomical boundary within the gland. You can clearly see a thick outer layer, the cortex, enveloping a dense inner core, the medulla. This structural division exists because the gland is a developmental chimera. Early in embryogenesis, 2 entirely separate cellular lineages migrate and collide, fusing together to form a single structure. These distinct origins dictate distinct behaviors. The outer cortex functions as a steady metabolic factory, while the inner medulla acts as a rapid response physiological alarm system. Recognizing the suprarenal gland as an embryological chimera provides a predictive model for its behavior. Its dual nature dictates its internal anatomy, its complex blood supply, and its specific clinical pathologies. The outer cortex is derived entirely from embryonic mesoderm. Looking at this histological cross-section, the cortex itself is further subdivided into 3 distinct, stacked functional zones. The outermost layer is the zona glomerulosa. Cells in this layer synthesize mineralocorticoids, primarily aldosterone, which strictly regulate the body's salt and water balance. Beneath it lies the middle and thickest layer, the zona fasciculata. This zone is responsible for producing glucocorticoids, primarily cortisol, which manages long-term stress responses and glucose metabolism. Finally, the innermost cortical layer is the zona reticularis. This layer maintains a steady secretion of androgens. The entire mesoderm-derived cortex operates as a highly organized chemical plant. Its distinct layers are completely dedicated to managing slow-acting, long-term metabolic homeostasis. Transitioning to the inner core, the suprarenal medulla has a completely different origin. It arises directly from embryonic neural crest cells. The medulla is populated by specialized chromaffin cells. These cells manufacture catecholamines, specifically adrenaline and noradrenaline, and release them directly into the bloodstream. This schematic traces a highly irregular nerve supply. Rather than synapsing in an intermediate ganglion, preganglionic sympathetic fibers from the greater splanchnic nerve travel from the spinal cord, plugging straight into the medulla. This creates a physiological exception. The chromaffin cells themselves act as modified postganglionic neurons to complete the neural circuit. This direct neurochemical wiring eliminates transmission delays. It is a required engineering solution for an instantaneous, life-saving fight or flight response. Zooming out to the full abdominal cavity, extreme spatial density forces structural compromises on the local anatomy. This transverse plane map illustrates the right gland wedged into a highly constrained space. It borders the bare area of the liver anteriorly, the right cruise of the diaphragm posteriorly, and sits flush against the inferior vena cava medially. The left gland sits in a different physical neighborhood. It lies adjacent to the stomach, pancreas, and splenic vessels anteriorly, while resting medially against the left celiac ganglion and the abdominal aorta. This anterior vascular map shows how proximity dictates drainage. Because it sits practically against the vessel wall, the right suprarenal vein is extremely short and drains directly into the inferior vena cava. By contrast, the left suprarenal vein requires a longer journey, traveling downward to empty into the left renal vein before its blood can join the central circulation. Human abdominal packing forces clear structural, spatial, and drainage asymmetries onto what are otherwise paired endocrine organs. Sustaining the massive systemic hormone output of a 4-gram organ requires an aggressively high rate of perfusion. This diagram shows the complex triple arterial supply feeding the gland. The superior suprarenal artery provides the first source, branching downward from the inferior phrenic artery. The middle suprarenal artery establishes a direct route, branching laterally off the abdominal aorta. Finally, the inferior suprarenal artery supplies the base of the gland, branching upward from the renal artery. Before piercing the tissue to supply the cortex and medulla, these 3 distinct sources form a dense, anastomosing network of small branches across the outer capsule. This triple redundant arterial web guarantees continuous perfusion. If one source experiences localized abdominal ischemia, the organ maintains backup supplies to prevent a catastrophic systemic failure. Adrenal diseases are strictly isolated to their embryological layer of origin. This split-screen diagram correlates localized cortical overactivity to clinical data outputs, defining Cushing syndrome. It's driven by excessive cortisol from the zona fasciculata, leading directly to central obesity, a moon face, a buffalo hump, and muscle wasting. Addison's disease presents the exact opposite physical state. It is a condition of total cortical insufficiency, most often caused by autoimmune destruction. This diagram plots the systemic effects of degrading cortical tissue. A dual metabolic failure occurs from the simultaneous loss of aldosterone and cortisol. Without these hormones, the body experiences extreme fatigue, severe weight loss, and dangerous hypotension. Because the cortex operates as a long-term manager, its pathologies manifest as slow, devastating distortions of the body's baseline metabolism. Pathology in the inner core presents an entirely different clinical picture. Here, the diagram visualizes pheochromocytoma, a functional tumor arising exclusively from neural crest-derived chromaffin cells within the medulla. Indiscriminately dumping excess catecholamines into the bloodstream, it triggers violent episodic spikes in hypertension, along with rapid palpitations, sweating, and severe anxiety. Unlike the gradual metabolic decline seen in cortical diseases, medullary pathology creates an immediate and volatile physiological crisis. The localized cellular debris or interstitial fluid from either of these distinct tissues is ultimately cleared via a singular lymphatic drainage pathway, ending at the lateral aortic or lumbar lymph nodes. From the triple redundancy of its blood supply to the strict functional isolation of its clinical syndromes, every aspect of the suprarenal gland is a direct, logical consequence of its origin as a fused embryological chimera.